Sickle cell disease in emergency department. Sickle cell disease in emergency department from the Ministry of Health Pockets Manual in Emergency, Saudi Arabia Ministry of Health. So sickle cell disease is genetic mutated hemoglobin S forms rigid polymer when deoxygenated, giving red blood cell characteristic sickle cell shape. This leads to increased blood viscosity and cell adhesion, produce intermittent vaso-occlusion. The vaso-occlusive phenotype of sickle cell disease, which is marked by higher hemoglobin, manifested with frequent painful crises, and is associated with higher risk for developing acute chest syndrome. The hemolytic phenotype is characterized by lower baseline level of hemoglobin and elevated markers of hemolysis. The clinical presentation history. Pain. What complication of sickle cell disease have you had? Pain, acute chest syndrome, stroke, infection, vascular necrosis, priapism, cholecystitis, splenic sequestration, renal failure, pulmonary hypertension, pulmonary disease, leg ulcers, vision loss. What surgeries have you had? Cholecystectomy, splenectomy, joint replacement, tonsillectomy. How often do you have pain? How often do you come to emergency for pain? Have you ever been on a chronic transfusion? What medicines do you take for pain at home? What is your baseline hemoglobin level and the medication? So you ask these patients about these questions. This patient is had chronic disease, so he know about himself, complain, and what's the complication, the surgeries, the pain, the history of visit of emergency due to pain, history of chronic transfusion, medication, and the baseline hemoglobin level. On the physical examination, the eyes, the mucous membrane for jaundice, auscultate for cardiac murmur, focal pulmonary abnormalities, abdomen, both liver and spleen, each pain location, and sign of infection, as tenderness, erythema, and fluctuation. Differential diagnosis. Common, rare, and extremely rare. The common differential diagnosis: vaso-occlusive crisis, infection, stroke, cholelithiasis, priapism. Common differential diagnosis: vaso-occlusive crisis, infection, stroke, cholelithiasis, priapism. The rare differential diagnosis: acute coronary syndrome, splenic sequestration, osteomyelitis, transient red cell aplasia. Extremely rare: hepatic sequestration, renal failure, splenic infarction, renal detachment, mesenteric ischemia. The workup. The workup in this patient: complete blood counts, liver function test, retics counts, ALT, LDH, bilirubin fractionation, direct or indirect, blood typing, and screen. And the management: pre-hospital and hospital. Pre-hospital: oxygen in respiratory distress, IV fluids bolus to hypotensive patient, administration of IV opioid in pain and venous access is obtained, transport patients who are already being followed by specific hematology service to the hospital. In hospital care, start D5 half normal saline at the maintenance rate. Opiate therapy, administer IV dose of opiate, morphine from 0.1 to 0.15 milligram per kg. The non-opioid therapy, antihistamines, acetaminophen, non-steroidal anti-inflammatory drugs. Assess the degree of relief every 15 to 30 minutes. And the disposition, admission to hospital if uncontrolled pain, blood transfusion needed, infections, complication of vaso-occlusive crisis, and thank you. This is how to deal with patients with chronic sickle cell disease in emergency department, according to Saudi Arabia. Thank you.